Oh, there's our, notice that it's going to get started. Mary, I was going to tell you something since you knew about my leg. It's really my back. So, you guys are all a lot smarter than I am. So I'm finally doing something about it. Okay, well, welcome to today's early intervention echo session. If you have not done so, if you will put your name and contact information into the chat. We are recording today's session. We use those for a variety of different reasons, as well as for education and quality improvement. You can also always go back and watch those recordings on our Canvas page or on our YouTube channel. Those can be linked by just clicking onto our website. They are also stored in iEcho. So feel free to share those out with whoever you feel is appropriate. If you've never joined an echo session, thank you. Welcome, and I hope you enjoy it. We are hoping that it is an interactive community. So ask your questions, put those into the chat. We have people that will make sure those questions get answered, as well as you can just come unmute and ask those questions. Case narratives, we will always do a case narrative. So that is a great way to learn from all these amazing colleagues on the call, to talk about different cases. If you're having a case that you're struggling with, working with a family, please consider submitting a case narrative. They're a great way to just brainstorm. I can't believe all the resources that you guys have on this call. But we do talk about individual privacy. So make sure that we are de-identifying that information. If you have any questions, you can reach out to a hub member. They all have an asterisk in front of their name, so they're easy to find in that chat. Key components of an echo session are always that didactic speaker, that case presentation where we come up with recommendations, and then really building that professional networking. So I don't know how many of you were on the call. Mary has heard about my leg issue. I met her one time and I had to fill her in. So it's a great way to just continue to build that professional networking up even though we are virtual and we may not see each other every day. But I know, that Mary has some great information around physical therapy. And if I had a question, I'd be able to reach out to her. And she's probably like, dang, why did I let Janelle know I was on this call? Because it's not always fun getting called out in a room full of people. So, again, renaming your profile so we do know who is on the call. For instance, if Katie, she shared something really amazing in my small breakout group, I would be able to know that I could reach out to her at DDI and know that where I might be able to follow up with some of those amazing conversations she had. So it's really a great way to just build that community of practice virtually. We're all in the same field and we struggle with some of the same questions, and sometimes we don't know who to reach out to, or we get kind of stuck. So this is a great opportunity to learn from each other and really connect with each other virtually. You can raise your hand, or like I said, always just put those comments into chat or questions into chat. We do submit a credit for attendance. So we ask that you fill out the survey, and then that will be dropped throughout today's session. And that's how we send out our credit for attendance. You can then use that information, hopefully, to go back and get some of your CEUs through each of your individual platforms. Canvas is where we store everything. So if you've not received a Canvas invite from us, you can reach out to us at earlyecho@usu.edu. Just put Echo Canvas in the subject line and we will get that sent to you. Case studies, I'll always do a plug for case studies because I know it's nerve-wracking to present a case, to talk about the case. If that's what you're nervous about, please reach out to me. I'll be glad to talk about your case for you and be able to ask those, get your questions answered. We do have social media, so we post information that is shared with us throughout the network, through different information. We share about all of our sessions that are going on here at the Institute. So if you've not done so, take a minute to follow us. I'm going to stop sharing and turn the time over to Chelsea, who I'm thrilled to is going to be joining us today. And
okay, that worked.
yes, it did.
Okay. So my name is Chelsea. I am an occupational therapist in Minot, North Dakota. I work at Trinity Health, specializing in the neonatal and outpatient pediatric population. I've been in OT since 2010 when I graduated from UND in North Dakota here. And I've been working in the NICU for about the past 13 years. In there, I specialize also in neonatal touch and massage, car seat fits. So I have quite a few roles. Today, my goal is just to talk about those babies that are diagnosed with NAS, what they look like in the NICU, and how we can help transition to home. I also threw in a little extra on feeding these babies because I know feeding tends to always be one of those problem areas. So with that, okay, so just a little overview of these babies that are in our NICU. They can be term or preterm. The preterm babies, due to their immaturity, they have less body fat, their total drug exposure time, they do tend to show fewer withdrawal symptoms than our near term or term babies. But then they're dealing with their preterm nature. The onset and intensity of withdrawal is going to depend on that drug of choice, the duration of the addiction, the last time that mom used that drug or medication, and then, as I mentioned in that first bullet, the age of the infant. There's a couple different approaches NICUs may use for managing these babies. One will be that pharmacological traditional approach, most often using morphine. There's also a newer approach called the Eat, Sleep, Console model. Currently, our NICU here in North Dakota is kind of doing some of the principles, but we're not fully executing that model, and we'll talk a little bit more about that. And then for these babies to go home, we need them to be taking all of their feeds by bottle in an open crib, maintaining their temp, stable vitals, gaining weight. They need to be weaned from their morphine or whatever medication was used to treat that withdrawal for at least 48 hours and stable, with that score of less than 8. The exception to that would be phenobarb. If they were on that for management of withdrawal or seizures, they can go home on that medication. Some withdrawal symptoms we may see, I kind of broke it down into these different categories. A lot of the research will break it down this way as well. The babies, you can read through these. I won't read through every single one, but we can see any type of intensity of these different things. Every baby is different, and then we just address each thing as it comes up. I would say some of the most common things, we see a lot of irritability, restless, that shrill, high-pitched cry. It is different, and it does come down. That cry does change as they are coming through that withdrawal. That cry is something that when you hear it, you know that baby is not feeling well. We see a lot of that increased muscle tone. The feeding symptoms can vary. Those respiratory symptoms vary from baby to baby. We see a lot of yawning, sneezing, and sweating. These babies tend to be hot. So looking first from that traditional pharmacological management standpoint, We use the Finnegan Neonatal Abstinence Scoring tool, and I have that on the next slide, so we'll go over that in a minute. But this is what we use to determine their severity of withdrawal. And kind of when to start our medications. This scores also help us to wean medications, or the providers, they're the ones that manage all of that. The scoring will start, I think I have that on the next slide, but we'll start 3 hours from birth, and then continue every 3 hours. Medications are going to be started when they have 2 scores greater than 8 or a score greater than 12. I have seen nurses score babies. I want to say we had like a 28 or almost a 30. The max score is 41. So that baby was pretty high. And then medications, like I mentioned, are weaned prior to discharge. Our providers follow a protocol. They wean by 10% when we have scores less than 8. And like I mentioned, they can go home in that phenobarb. So I mentioned earlier that morphine is the most common one. That's the one I see most often in our NICU. Looking through the research, that's typically the first line of treatment. Phenobarb can be used as a second line of treatment, especially for those polysubstance or opioid babies withdrawing from that. Or of course, if they've had seizures. I have seen us use methadone. So sometimes our babies that the mom is on a methadone program, that baby is still going to withdraw from methadone. I have seen us use methadone instead of the morphine. Sometimes we may also use clonidine instead of the phenobarb as that second line of defense. But all those will have to be weaned before going home. Okay, so here's that Finnegan and the points that the nurses are looking at. So again, we're scoring within 3 hours of life and then continue scoring every 3 to 4 hours. The score should be done after that baby is fed, after all their needs have been met. Because of course, if you've got a crying, hungry baby, that's going to present and give you some high scores on some of these when truly their need was just feeding. We don't wake a sleeping baby to score them. And then, like I said, this determines the initiation of that pharmacological therapy if needed. So you can see here different, I guess, symptoms are going to give them different scores. Our nurses are able to put that in computer, gives them a score for them. Within sleep, there's a 3-2-1 system. Did they sleep more than an hour, more than 2 hours, more than 3 hours after feeding? What does that moral look like? We even have mild versus moderate tremors that we're looking at. We look at their temp. Are they yawning? Do they have more than 3 sneezes during an assessment period? Everything to their respiratory rate. Are they having poor feedings? Or on the opposite of that, are they having this excessive suck where they just never seem satisfied? They're looking at their skin, their stools. So an entire body system assessment every time they look at that baby. So then looking at the second approach, it was that eat, sleep, console model. So the goal with this model is for neonates to function as normal as possible. So just as it says, they're going to try to eat, sleep, and console. So in eating, we're looking at, are they able to coordinate feeding within 10 minutes of showing hunger? Can they effectively breastfeed for over 10 minutes? And are they able to eat at least an ounce? If that baby is newborn, we're not looking for them to eat an ounce, but the appropriate feeding for their size, and the providers will help determine that. For sleep, can they sleep undisturbed for at least 1 hour after feeding well? And then console, can they be consoled within 10 minutes and stay consoled for at least 10 minutes? With this model, parents or families should be the ones delivering this care. The goal is to not go to pharmacological, but to try to just meet their needs this way. So with that, somebody really needs to be present with that baby to meet that need 24/7. So that's where ideally the family would room in with the infant. Some people talk about switching family members. The dad comes in, the grandma comes in, the mom comes in, taking turns. The family is educated on what would be appropriate consoling methods. We support a low stimulation environment. They should be fed on demand. Breastfeeding is highly encouraged in these infants if that mom is not actively using. If it's, if they're on methadone or Suboxone, that's an approved breastfeeding medication. If that baby is not feeding well, but still able to be consoled, we may look at using an NG tube up through the nose down to the belly to meet that feeding need before they would go to a medication. And then studies are showing that this is decreasing the number of days from birth to discharge with this approach. In my particular unit, one of the reasons we're not fully committed to this model is somebody has to be with that baby 24/7. Our nurse ratio, we're short nurses as seems to be a pretty common theme throughout the hospital. So we don't have somebody that can just sit with these babies one-on-one all day, every day. I live in a rural area. Some of these families are coming from an hour or more away, have other kids. It's hard for them to be present 24 hours and be there with them their entire stay. Some of these babies are in our NICU a month or more. Just depends on that withdrawal and how they're doing. But so that's a big commitment that for some families it may work, but for some of our families it's just not a reliable. So we do our best and try to reduce that medication, but ultimately that's just not working in our unit right now. With this approach, if they're unable to eat, sleep, or console, the provider may look at adding a medication approach as well, going more towards that morphine. With that, that can vary too and is going to be provider dependent, whether it's a PRN dose or if it's a scheduled dose and weaning. So it does have that medication. If have that baby at the score of almost 30, they may just not meet the demands of this model. Okay, so moving on to, I have an entire section here on those non-pharmacological supportive strategies. These are things that I'm doing with the babies, things our nurses' aides will come in, how we console these babies. And a lot of these things, I'm breaking it down into the symptom and kind of how we can manage that symptom. These are going to be appropriate both in our NICU and for going home. So we'll start with that inability to sleep. Some things that we'll do to help support sleep: decreasing that environmental stimuli, getting low noise, low light, try to limit visitors, limit the noise that the visitors are making, feeding on demand, feeding small amounts at frequent intervals. If you go back to some of the symptoms, sometimes reflux, upset stomachs, emesis, those types of things are one of the symptoms they can have. So smaller, more frequent feedings are going to be better on their GI system. If they are sleeping, we try to minimize handling. It's a natural response as the baby's sleeping and parents especially are holding. We want to stroke them, rub them, rock and move, or we go from upright to laying down. Our arm is tired, we move them. That's a lot of moving that can disturb their sleep. So just trying to minimize that moving and handling once they do fall asleep. We use a swaddle in our NICU. We have sleep sacks that really give them a nice firm containment type hold versus just laying sprawled out. If they're sprawled out and they have that hyperactive moro, they're going to be startling themselves awake. We encourage skin to skin holding, soothe with slow rhythmic swaying or vertical rocking. So what I mean by vertical rocking, I'll just back up here, is like an up and down movement. That has been shown to be more calming to the nervous system for these babies versus just your traditional rocking. We are trying to maintain that appropriate temp, so making sure that we're not overdressing or underdressing these babies. Like I said, they tend to run a little hot, so we do use a pretty thin sleep sack and usually just a onesie. And then we're also following with all this, those AAP safe sleep guidelines. So that would be firm, flat surface on their back, alone in their bed with nothing extra. So we really are promoting that safe sleep in the hospital setting and try to model that for families. Sometimes if we've got a super refluxy baby, we will elevate that head of the bed with the goal to get that head back flat before they leave. Okay, the next few systems, if they've got that hyperactive moral reflex still there, again, using a swaddle, I like to use a swaddle that's like a stretch knit or a sleep sack. A lot of times if we're using muslin blankets or those stiff hospital blankets, as soon as that baby startles or moves, and these babies tend to be pretty strong, they're breaking out of that. Well, now we're into a cycle of not sleeping again. So I like something that's stretch knit. It allows that baby to stretch and move and yet come back into that recoil, into that flexion. Again, limiting stimulation so that we're not startling them, approaching with a calm talk before we touch. And then again, that's that slow rocking, giving them some movement and stimulation can help that moral reflex to integrate. Increased muscle tone. I didn't retype them out, but basically the muscle tone, everything under sleep, plus I will do massage with these babies. I'll try to teach families, but even just like a basic back rub where I should have brought a baby, but I will just one hand down the baby's back, nice slow movements. It doesn't need to be anything aggressive like how we would go to a massage, but even just that nice slow movement down the back can be so relaxing for that baby. That whole cuddle and gentle rocking for that tone. Sometimes too, diaper changes can be really hard with these babies because they're just so tight. So we will swaddle the upper arms, try to get them relaxed, get them calm, and then try to change that diaper. If they're fighting you and their entire body is in a stress state, it's going to make something like a diaper change even more difficult when they're already tight. And then once they're term and home, as they're tolerating it, but getting them unswaddled, letting that baby stretch and move against gravity, get them on their tummy, getting them that floor time too, to help that tone progress to where it should be. On the other side of that, once you're home, you can always look into some alternatives such as physical therapy. If they've got any tightness in the neck, can work on some of that. Some people will use chiropractors. They've got some techniques that can help decrease tone and tension in babies. So that's going to be a parent choice as they go home, what they're comfortable with, but it's what I've personally, not that I had a baby with NAS, but I did use chiropractor for my babies. So I believe in that, but it's an option if parents want to explore. Tremors, again, a lot of the same things, but decreasing that environmental stimuli, getting low lights, low noise, limiting the visitors, clustering care. We do quite a bit of this in our NICU so that we can decrease the handling. A lot of times these tremors that we see, it's not that they're laying in their bed tremoring. It's more once we unswaddle them, that tremor will come. Once they're swaddled and contained, they're calm. So that's where decreasing the handling can be helpful. The more they tremor, a lot of times the more to see tone increase. They just kind of all piggyback on each other. So we come in, we will do everything we need to do with that baby at once. We change the diaper, we get them fed, and then get them swaddled back up to help control that tremor. Sometimes as we're going through cares, you may need to consider taking what we call a timeout. That baby's showing stress, instead of just going through and getting it done, just taking a minute, helping that baby calm down, maybe that's swaddling the arms, giving a little pressure to the head and the feet, a little containment hold, help them to calm down, give them that time out, decrease that stress, and then move on. That's going to be a better method than just getting through it as fast as you can. And then swaddling that baby to help control that tremor. Okay, some other symptoms we may see, that nasal stuffiness, allowing more time with feeding to just rest between sucking. Sometimes babies breathe through their nose, and they're especially breathing through their nose when they're feeding. So if they're stuffy, that can make feeding difficult. So just following that infant cues, giving them they're not going to think they need a break. but giving them a break, letting them rest, kind of clear their throat, that nasal cavity, and then come back to it. We will use saline drops just to ease some of that stuffiness, and then avoiding frequent suctioning. So our nurses will use like wall suction to sometimes get boogers out at home. People are using like bulb suctions or the nose Frida. They're like, oh, there's boogies in there, we got to get them out. But the more you do that, if you're constantly doing that, you're just going to damage that tissue, that mucus tissue in the nose, and actually create more swelling, which will actually create more stuffiness. So saline drops with every diaper change would be a better option than trying to go in there and suck it out. We'll go over to excessive sucking. We'll offer the pacifier for non-nutritive sucking, try to meet their need that way, consider small frequent feedings, and then avoiding overfeeding. These babies, they will think that they need to eat like 4 ounces and they're only like 3 days old. That is way too much food. That will just make them uncomfortable on the other end. So our providers usually guide us into how much that baby should be eating roughly. And we'll try to do small frequent feedings instead of overfeeding them and meeting that baby need, and then switching and offering that pacifier. GI symptoms for reflux, we'll hold them upright for 30 minutes after the feeding. If it's worse and that's not meeting it, or if they're having weight loss, the diarrhea, the diaper rash, ultimately just consult the pediatric provider, but just know that these are symptoms that can occur because of the withdrawal, and maybe one of them that continues even after going home. Hopefully, if they've been in the NICU, they have a plan for those things, but if not, just advise parents to contact their pediatric provider on those. Okay, poor feeding, again, a lot of the same, I guess decreasing environmental stimuli, that's going to be a big one. If that baby's distracted, they're going to have a hard time feeding and focusing on that. Small feedings, swaddling, feed on demand. I do have side-lying, pace bottle feeding, clustering care. I have an entire section on feeding, so we're going to come back to what some of those techniques are. Just here's a few, yes, brief reminders on addressing that. Regurgitation, emesis, getting that baby to burp, sometimes that can be difficult. Again, they're tight through everywhere, tight through that core. So it can take a minute, but if you've got a baby that's puking quite a bit, it's going to be really important to get that burp out. A lot of times in their excessive sucking, that over eagerness to eat, they end up taking in quite a bit of air. So it's important to really get that burp out if we want to decrease. Holding them upright. And then small feeds, again, limit stimulation. A lot of the same things are going to apply to that as well. And then here's just a few other supportive care ideas, things that we do in our NICU, things that can be done at home. Swaddle bathing. If you're not really sure what that is, I have a picture of it here. So at home, you obviously wouldn't need the plastic liner. That's going to be a hospital setting thing. But getting the baby in a light blanket, swaddling them up, and then that entire baby and blanket go into the warm water. From there, you can release just one limb at a time, gently wash that, and gently tuck it back in. This will just help keep that baby regulated, calm, quiet, give them that containment that they may need. If they still have some tremors, will help keep those calm during that bath, so that we really make bath time an enjoyable time. That warm water can really help with their tone. Most babies love it. Wash the hair last, because that of course is going to cool them off if they're going to sit there the whole time with a wet head. The other thing I like to do is keeping the room warm. I know for my babies at home, I had like a little portable heater, or I would run the shower to like make the room just a little bit warm. The worst thing is coming out of that bath. A lot of times babies don't like that. So the more we can make that enjoyable, have everything prepped and ready so that the baby can come out of that swaddle, that wet swaddle, into a dry towel in a warm environment, that'll keep them hopefully a little calmer, so that we don't start to spiral into some of those symptoms. Other things we use, sound machines. You don't want to run it too loud all the time, but definitely we find it helpful, especially with the noises of the NICU, to have a just white noise in the background, kind of cut out some of the noises of the NICU to help them sleep. We will start playing soft, age-appropriate music, lullabies. A lot of people talk about Mozart for babies, that sort of thing. Again, not all day, every day, but throughout the day, we'll start adding that. We encourage parents to talk and sing to their babies. We will use some infant swings, but again, want to caution following safe sleep. It's easy to get the baby calms nice in the swing. It's easy to get in a pattern of just letting them sleep there all the time. So we really want to encourage that the swing is we do about 20 minutes in our NICU and then stop it. We get them out. Sometimes they are in there a little bit longer, but we don't let them sleep in there. We want to get them out into their safe sleep surface, crib, bassinet, whatever that may be for that family. But the swing is definitely a helpful tool so that parents can, cook, shower, use the bathroom, as long as somebody's keeping an eye on that baby as well. And then baby wearing, something we would love to do in our NICU, but being a hospital setting and cleaning that baby wearing device is usually an issue, but we'll encourage families, if the baby is appropriate size, getting a carrier of some sort. That way parents have hands free, but that baby's close to mom or dad. They really calm just being held. Okay, this might be a good place to pause. Is anybody having questions about that before we go into feeding? I don't know if anything's come through. I haven't been paying attention.
I haven't seen any questions pop up in chat. I don't know if
Okay.
we had anything or.
And they can all come in later, but I just figure we're kind of moving into feeding. So I thought I'd pause a minute if anybody had anything. Okay, we'll go on. So feeding infants with NAS. Infants, especially with opioid exposure, are going to lack that physiological stability, and we see quite a few feeding difficulties with these babies. Uncoordinated suck, you'll offer the bottle and they just look like they're stuck in a rooting reflex. They just struggle to coordinate that suck, latch to the bottle or breast. We can see a hyperactive gag, a lot of those GI symptoms we've talked about. Weight loss, sometimes they're tremoring and their tone is high. They are using more calories than they're consuming. So sometimes we will see our dietitian and our provider recommend a higher calorie formula just to prevent that weight loss and promote good weight gain. On the other end of that, we can also see, like we've talked about, that excessive suck. One thing to kind of keep in mind with feeding from an early intervention standpoint is that suck swallow reflex is going to integrate at about 3 to 4 months corrected age. And at that point, we can start to see feeding difficulties arise again. Up to that point, that baby may have been relying on that reflex to feed. And if they didn't establish some strong foundational skills, sometimes we can see feeding problems start to occur, which I'll see them in the clinic at this point and usually like, but why? They left, they were feeding so good. Well, if they were kind of in a compensatory pattern for some reason, or their skill just isn't there, it makes sense when that reflex starts to integrate. Some of the things we're talking about here, you can continue to try if this occurs, but ultimately they may just need a feeding consultant or feeding consult from a specialist, an SLP or an OT. There may be something else going on, but we'll go over a few things that hopefully can help. So I included this slide just to kind of show hunger cues versus when they're satisfied versus those stress cues. So those hunger cues, moving arms and hands, rooting, bringing those hands to the face, they're going to try to suck on anything that comes nearby, and they're starting to wake up, look alert. And I've seen actually parents continue to ignore these satisfied cues. So if baby's pushing the bottle out, slowing on their sucking, they're sealing their lips, they don't want anything to come in, turning their head away. Sometimes it's even just gaze averting, just turning their eyes away. They've kind of fallen asleep, they're not able to be re-alerted. And they're just stuck in like a non-nutritive suck. That's gonna be cues that they're done. But sometimes parents, I'm gonna say parents mostly in our NICU, get stuck on a volume. They think the baby should take so much that they start to ignore all these signs. The baby's sealing their lips. Okay, that means they're done. Instead, I have seen people try to force that bottle back in, or even overstimulating the bottle, twisting and turning it. Eat more, eat more. But we want to respect those cues. If we don't respect those stop cues, we may start to see some of those stress cues, which some of these stress cues are going to be, could be during a feeding, it could be after a feeding. These actually could come at any time, but signs that that baby is stressed, averting that gaze and turning away, facial grimacing, increased respiratory rate, gulping, drooling, just not coordinated in that feeding, fingers playing or like a stop hand, starting to arch, pushing that bottle out, and frequent yawning. And I don't know where that went. I'm sorry. I apparently hit a button.
See, you gotta just love technology sometimes.
There, got it. Like, I don't know. Oh, I suppose my papers are under. Okay, how do I back up? Oh, here. Okay, sorry, small glitch. Here we go. Okay, so feeding babies in the with NAS in the NICU, they could be breastfed or bottle fed. Again, breastfeeding is going to be if they're on methadone or Suboxone, if they're currently using illicit drugs, or if that mom tested positive for illicit drugs, we're not going to be using their breast milk. For obvious reasons. So that's going to be okay, where am I going with this? Other prescription drugs are going to be at the discretion of the provider, depends on what they were on. Sometimes we see moms on some different psych meds or gabapentin. So that's going to be up to the provider on what meds are going to be safe and which ones are not. Studies indicate that breastfeeding can successfully reduce the need to initiate medications, the duration of medical treatment, and then the length of stay. But a little bit of that methadone is most likely crossing into the breast milk, which does help that baby withdraw, as they're getting just that little bit from mom as she continues on those medications. We will follow the baby's cues and be flexible in their routine. If that baby wants to eat every hour, we'll follow that. If they're going to sleep for 4, we try to follow that. We want to really nurture that infant and mother relationship. So even if that mom is not able to breastfeed, helping her to continue to bond with that baby, push our judgment aside, and support that mom, baby, and that family as we would any other baby coming into our NICU. We want to promote a calm and comfort for both the infant and their caregiver. Every baby is going to be a little bit different, so how we calm them can be different, but some things that can help is sometimes a gentle patting, massage before a feeding, decreasing eye contact actually can help. So getting them, we'll talk in the next slide, but getting them in a sideline position, too much eye contact can just overstimulate them. Decreasing that stimulation again, decreasing those distractions, a little bit darker environment. Sometimes those bright lights can be overstimulating for that baby, and if we want them to try to organize eating, we need them to be a little calmer. We've talked about some of those other cues, I guess. So techniques that we'll use, again, like on repeat, but it's so important, a dark and a quiet room. Some infants can tolerate gentle rocking as we're eating. Some that just puts them to sleep, or it's too much vestibular input. that they're just not ready for. So sometimes we have to get parents out of a rocking chair into a chair that doesn't move so that they can just be still. I like to use an elevated side lying position. So that's the position in this picture here. Getting that baby on the side. And what that's going to do is it gives the baby more control of the flow of the bottle. So as baby takes a suck, if that suck swallow is not quite coordinated, this position allows the baby to coordinate the swallow versus gravity pulling the fluid to the back of the throat. If they're not quite ready, it's just going to pool in the cheek instead of the throat. This is also going to be your breastfeeding position. So if you do have a baby working on breast and bottle, we're keeping as much similar between the two as we can in this side lying support. I like to swaddle with hands to midline, or this baby here is a little bit more mature holding hands to midline. But if we've got a baby that's a bit more restless, I will swaddle. And I always want hands up and close to face, that we start creating that motor map of hands to face, hands towards midline for eating versus hands down at our sides. What we do matters from the beginning, from birth, and we're creating those motor maps. So we want to start teaching these babies hands to mouth for feeding so that we can progress towards holding the bottle, progress towards self-feeding. If our hands are at that side, we're creating the wrong motor map for feeding. So hands up, again, decreasing that eye contact just for that feeding, especially as that baby is in more, showing some of those withdrawal symptoms. We will use a slow flow bottle, usually to start, especially those babies that are uncoordinated or even overeager, slowing it down a little bit so that they don't get in a gulping pattern. Most often I will use a Dr. Brown bottle. It's just what I find works best and can get slowest. I will start these babies usually on a preemie bottle. Even if they're term, it sounds weird because it's marketed as a preemie, but it's what they call their slow flow. They also have a nipple called a transition nipple, which is just a little bit slower than their level 1. So it's what we stock in our NICU. It's what I recommend, especially if they're breastfeeding as well, and it's what works well for us. I will also consult parents, and if they have bottles that they've used at home, I try to get them transitioned to that before they go home. And we'll support whatever they have. If they have other kids, I'm not going to make them go buy a ton of new bottles unless what they have at home isn't working. But I will start there with the slowest flow that that bottle makes. Frequent burping can help, and then keeping consistent. Well, sometimes what we see is one feeding maybe was more coordinated and more sloppy. The next feeding was great. Sometimes what I see is families and nurses will switch nipples, switch bottles. Well, this one didn't work. Let's try this one. Okay. But every time we switch it, that baby is not going to know how to adapt, how to change. So we'll keep consistent. And if ultimately after a few feedings, something's just not right, then we'll make one switch and try to stick with it. But trying to understand that one feeding to the next may not be the same, but what does the average look like? What does it generally look like over time? Is that the best bottle? So again, these are strategies that we are using in our NICU with every single feeding, and these can continue to be appropriate for those babies up to 6 months if needed. A lot of times once they're calm and content, parents will try to hold them in that traditional cradle feed. And parents are more than willing to try that. I usually say 1 to 2 months after they go home, go ahead and try that. But if baby is coughing, choking, gulping, just getting wide-eyed and seems in distress, then they're not ready for that more upright or laying down approach, and they need to come back to this side lying. I guess one more note I had on bottles was not to fall into the marketing ploy about bottle flow. So of course, every bottle is labeled level 1 up to 3 months, level 2, 3 to 6 months. It leaves parents thinking that at 3 months that flow needs to change, and that's really just not necessary. You could have a 1-year-old still using a level 1 nipple because ultimately it's whatever meets that baby. breast never changes flow, there's no need for that bottle to change flow either, unless that baby is showing signs that they're ready for it or they need it. On the other end, if it needs to go faster, that baby may be sucking and just not getting anywhere, seeming frustrated by the bottle, then by all means try to go faster, see if that baby is a little bit more content. But if they're having that gulping, wide eyes, and drooling all over, then they're just not ready for that faster flow. So, but just know that it doesn't have to go just because the bottle is marketed that way. Okay, so there's feeding. I just have, as I was going through and reviewing all my things on NAS, I just wanted to include one more slide just on some of those NAS outcomes that are in the research. I didn't include all the articles that these come from in my references, but if you want them, I can get that references to you. There's just a lot of studies on NAS outcomes. So in general, in the research, birth to 5, we're seeing an increased risk of hospital admission, and then lower cognitive, language, and motor scores. Those school-age kids are more likely to require classroom therapies or services, lower motor and cognitive scores, lower national test scores, more likely to have language disorders, learning disorders, abnormal behavioral development. I see a lot of kids with emotional regulation difficulties, increased incidences of strabismus and nystagmus, and then some mental health conditions. So I included this just kind of as an FYI when we're working with these kids from birth to 3 in that big developmental timeline. How can we kind of start looking for these and help these kids move through some of that? So just kind of a good to know. My reference list, and thank you. I'm open to any questions.
Let's see. Thank you so much for that great presentation. I was really interested in the fact that you're not supposed to use those nasal sections. I wonder, is that the same for all kids too?
Yeah, technically, yeah, you don't want to overuse it because then you just damage that and it's really just creating more swelling. Intermittent would be okay, or like during sickness, but some people get a little carried away and like every care set, they're suctioning them.
That was interesting. My other question that I have, since I have the floor, I'm asking my questions, right?
Yep.
My other question was, does that rocking that you suggested, that bouncing up and down, does that help with other type of babies that are colicky? And is that a suggestion we should provide to families?
I think it can. I think it's a vertical movement versus a more horizontal that can be more calming and organizing to that neural system. It's worth a try, I think, in any regard. Why it works, I'm not, I guess, not super sure, but like every course I've taken, they all recommend that vertical rocking, more of a bounce, and it does work.
Hey,
so I would say my baby that was a little colicky, yeah, I held him upright and I would just walk, which was probably a little bit more bouncy. So I would say suggest it to everybody, because a lot of times people do. As a provider, I tend to hold upright, but so many people tend to just cradle and rock that way. So absolutely change that position and see if that helps. It's one of those things when you're stuck in that moment of any sort of cranky kid, you just can't think outside the box to change things up.
Yeah, yeah. So now there's some questions. I'll quit asking all my questions and go to other people. So Jennifer says, do you have a preference of nose Frida or ball suction?
For home nose Frida, I think it's safer. But that's just my opinion. Ask your medical provider.
So for those of us who haven't had kids for like 20 years and we just used to pick their nose, just kidding. What is a nose Frida?
Oh, it's this really weird device that has like a tube that goes in the baby's nose and then a filter, and then a really long tube that goes into the parent's nose so that the parent is the suction.
Okay, that's what I thought. My kids have started doing that and it just kind of grossed me out, but it sounds like it's a good
so
practice.
It works though.
We
Really
always
gross.
use the ball. We use the ball suction, but they started sucking their own kids' nose. And okay,
Yeah.
good to know that that's not just them. That is something out there.
It is a thing. I think Nose Frida even just came out actually with an electric one, which would probably be safer because the suction's probably more regulated, but that's just my opinion.
Any other questions?
So I have a question. I have a mom who had a baby, not an NAS baby, but he was on some really strong medications in the NICU, and she feels like he came home kind of addicted to those medications. Do you see that much? How often does that happen? And any idea? I mean, I'm assuming just the same things that you just went over to tell
Yeah.
that mom to try.
Absolutely. And it can happen if you've got some of those super tiny sick babies that were maybe on, sometimes those babies do go on morphine if they were intubated or had a surgery. I would say we don't see it a lot in our NICU because they're not on it super long. If they were, we're weaning before they go home and being aware of that. But absolutely, they're essentially, yes, not an NAS baby at birth, but they're still withdrawing. All of these suggestions would be super helpful for that baby.
And then Jennifer, I just saw you on camera and I love the color of your glasses. So nice job. Hey, well, if there's no more questions, I'm going to thank Chelsea for her time. But if you have any other questions, please reach out to any of our hub members. We can connect you to Chelsea and her contact information. So I'm going to ask Olivia to come unmute, and I'm going to share my screen, and she is doing our case presentation today. So thank you, Olivia, for sharing with us. Okay, take it away.
Hi.
You just tell me next.
Okay, I'm Olivia. I'm a PT at DDI Vantage in Salt Lake. And this is my presentation. So I just tell you next. Okay, all right. Work in early intervention 0 to 3. I have a little boy who has a history of a TBI at around 8 months old. His medical records say shaken baby syndrome. He was discharged from his NICU, came home, had a repeat of similar symptoms, and they took him back. He ended up having brain surgery. He is showing pretty significant delays in all different areas of development and also has a cortical visual impairment. He's missing his left pectoral muscle, so there's a possibility that he might have Poland syndrome, but it hasn't been officially diagnosed. He lives at home with both of his parents. He's the only child. He spends most of his time during the week with his paternal grandmother, who also works from home while she's watching him. So he spends a significant amount of his time in a playpen or some kind of container. Due to their ongoing DCFS case, parents don't feel comfortable putting him in daycare. And he's been with me for about 6 months.
Can I just ask one question before we move on?
Mhm.
Tell me what Poland syndrome is. I'm not familiar.
It's a genetic condition that is indicated by sometimes they have webbing in between their hands, but it's mostly just missing one side of your pectoral muscle.
Okay, thank you.
Sorry. So his motor skills are progressing really well. When I first started seeing him, he was kind of like a lopsided sitter. Now he sits really nice. He is starting to crawl. He can army crawl. He's pulling up to stand. He's starting to cruise. His motor skills seem to be going quite a bit faster than the rest of his skills. So another area of concern is the way that he interacts with toys and his overall just play skills. He primarily only plays with toys that light up or perform an action, like if it spins, that's kind of like a repetitive action that he'll get into, or rolling, anything like that. Sometimes during the lights or the rolling or the spinning, he will sometimes show some kind of like stim behaviors where he will shake his head back and forth and close his eyes, or he'll flap his hands. His language is also an area that isn't coming along quite as fast as his motor skills. He mostly uses grunts or cries or open vowel sounds, occasionally open vowel sounds, mostly just crying. Not pointing, he's not gesturing. We're working on him using his eyes, but with the cortical visual impairment, it's not going super well. He doesn't show much understanding when mom gives him directions or talks to him. He'll sometimes look at her, sometimes kind of ignores her, and inconsistently responds to his name. So our goals are looking at items when parents point to them. So like, where's your bottle? And seeing if he'll just turn in the direction of the point. Starting to work on some gesturing or verbalizing what he wants to caregivers. And then playing and interacting with mom. So peekaboo, rolling a ball back and forth, putting toys in and out, anything that can kind of that social interaction during play. Barriers that I've run into so far is just the time that he's with his actual parents. Both of them work full time, so he goes to bed really early. So he goes to bed at around 6 and they bring him home, they feed him, and he goes to bed. I have asked to do visits with the grandmother since that's where he spends the majority of his time, but because she works from home, she's not super interested in doing visits with me right now. Getting him to engage in activities that are more back and forth turn taking without using lights or one of those kind of like spinning activities that he really enjoys. Back and forth attention is really hard. Insurance difficulties, his parents have not great insurance. They have kind of like a discount insurance. So anytime he needs an MRI, anytime he goes to a specialist, it's quite a bit of money for them. And he didn't qualify for the medically complex waiver. So talking mom through how to communicate that with her medical team. I've talked with parents about the use of containers, and we kind of compromised on a larger playpen that at least allows him to move more. It's probably 6 feet-ish by like 8 feet-ish. So not huge, but at least he can move around as opposed to being stuck. And it has a firmer bottom. The one that he was in for the majority of the time kind of had that like domed bottom. So anytime he tried to transition, tried to sit on his own, he would kind of just tip over. We've been working on modeling sign language more is what we're working on, just so because the eye gaze isn't going super consistently, trying to get another form of communication, but it's not, haven't seen him really engage or participate much in that yet. And with his visual impairment, working really hard to make his environment as contrast heavy as possible, so we have the best chance of success for visual engagement. So things that I would love some suggestions on is how to progress kind of his pre-language skills and communication, getting him closer to verbal communication. Mom's priority is she really wants him to talk verbally. And so we tried the eye gaze, we've tried the sign language, hasn't been super successful. How to get him closer to that. Helping him with his interaction with age-appropriate toys, keeping his visual engagement, but also kind of helping him get out of the cycle of if it's spinning, if it's lights, something like that, of just wanting that repetitive behavior. Brainstorming more kind of like social caregiver interaction during the day, things that I can suggest to give to grandma or just to parents that they can do in the car or at the dinner table, something with like the limited amount of time that they have with him during the week. And just any suggestions on strategies when he's playing, when he's moving, and with language, considering his visual impairment, that'll help set him up for success. I have noticed a big difference in his attention between me and his vision therapist because her face has a lot more contrast than mine does. So anything similar to that you guys can think of.
I'm on mute, so nobody could hear what I was just saying. We are gonna go ahead and put you guys all into breakout groups and have these discussions. We will be moving Olivia into the different breakout groups because I know, Pat, you already have probably 5 questions that you want to ask, and I see Marla's hand up. So, Marla, will it be helpful for the whole group to know your question, or can you wait till she's in your room?
I just wanted to ask if you knew what cortex of the brain was impacted by that TBI and what surgery was done.
He had a stent placed too, and it was basically like a buildup of fluid, is how mom explained it to me. I don't know the exact cortex that the damage was in, but according to the medical records we got, they kind of just said diffuse, cortical damage.
Thank you. Is that okay, Janelle?
Yes, that was perfect. Thank you, Marla. And then I don't know if you see in the chat right there, that Katie's saying wear goth makeup. That will increase your contrast.
I have tried like lipstick and
Oh.
it was pretty successful.
Okay. All right. So, Kurt and Shelby, your group is going to start taking that question number 1 around pre-language. Kirsten and Kate, you are going to take on that age-appropriate toys. Crystal, your group is going to talk about brainstorming more social caregiver interactions. And then Pat and Rebecca, your group is going to be talking about strategies in play. I did email those to the hub members a little bit late, so check your email and you should have that full question in there. So Shayna, if you want to go ahead and put us all into breakout groups, and then, like I said, Olivia, I'll be jumping in and removing you to different groups. I'm excited to hear what you guys are all going to come up with. Who took note?
I took the first, but then Kate took over, so I'm gonna let Kate do it.
Okay.
Sorry, hold on, trying to find them. There was just so much talked about that I don't even know, and so many good ideas. Let's see. One that was really cool with interacting with age appropriate toys, and just building the interactions with like variety and play, was using like bright paints on the toys. So having those colors and just exploring paints and sensory play in a different way.
Oh, that's a good one. Okay, Pat, how about your group? And you're on mute, so you're probably sharing a brilliant idea. And
I'm back.
okay.
So Bree, we talked to Olivia at the very end. So we suggested some of this stuff to her, but Bree said that you can have balls that light up or balls that go in and then pop out, sort of to switch up just being attracted to things that light up or things that are flashing and whizzing. So that you can just sort of build on the play activity. So our thing was how to get, given his vision stuff, how can we get better play? So it was these bath toys that she said can light up. So I don't know any of that stuff, but that's what the suggestion was.
That's awesome. Okay, Shelby, your guys' group. I don't know who took notes. Probably Kurt. See, I was trying to give you a break, Kurt, because I always pick on you or call on you, not necessarily pick. Sorry, guys,
Hey,
but
yeah,
call
well,
on
there
him.
you go. So a lot of good suggestions. One of the suggestions I thought that was kind of talked about a lot was around using, because our question was progressing pre-language skills and communication to get closer to verbal language. One of the things we talked about was using specific times to do that. Maybe it's a meal time and he's got a favorite treat, and we do the kind of pause and wait for them to request it, and some sort of communication done that way. A lot of other good suggestions. Some of them, oh, you only wanted one, sorry.
I only wanted one.
That's
Thanks for, you understood the assignment. Nice, Kurt. I like it. Okay, well, we will, Kate will type those up. So if all hub members will email those to Kate, and then Olivia, we will send you a list of the recommendations. For everybody else, those are always on our Canvas page. So you can go back and find all these amazing resources on there. I'm really excited about our September 1. We are going to be having Jamie Sill from Rainbow Kids. She's a social worker that's going to talk to us about how do we have some of these tough sad conversations that sometimes families have to have. And so join us for our September 4th. I hesitate to say September because then I know the temperature is going to change to cold.